I'm just going to kick it off with having our healthcare chair, Dick Gottfried, kind of look through our budget highlights and give us a little bit of an overview. I gave an overview at the very beginning that really talked about the Medicaid redesign plan that cut $400 million to hospital spending, but increased overall Medicaid by 3%. The Medicaid redesign plan also made modifications to the $300 million and restored funds from the previous fiscal year's budget, which includes $94 million to reduce across the board cuts for most Medicaid providers, $70 million for indigent care pool funding for public hospitals, and $33.2 million to restore enhanced safety net hospitals. We will also talked about the MRT 2 plan, which now I think is very complicated, and I think our chair can tell us a little bit about what's going on with that. That there was $94 million put in to reduce proposed across the board reductions for most Medicaid providers, $70 million to restore, again, the indigent care pool funding. And then we also had this $17.25 million to restore the managed long-term care quality payments that would incentivize NLTCs to collaborate with providers to develop high quality programs, and then $22.5 million to restore half of the workforce retraining and retention funding. And I think that, our district specific points is that in any given year, cuts to Medicaid mean that New Yorkers suffer, that hospitals go without, and that nursing homes close, and that there are staff shortages. And when we cut healthcare spending amid a crisis like this one, that means that a lot of people will die. And I think that I know that that's not something that we can't avoid and ignore. And I think that it also means that we are cutting already non-existent resources too from those suffering from this virus. And we already know that we don't have enough nurses and doctors and ventilators and tests and countless other elements that we need in a robust public health. So we're answering to having to cut in the midst of a crisis. So our chair has been incredibly vocal and incredibly hard fighting in this crisis, and I just wanted to say thank you to my friend and mentor, Dick Gottfried, and I'm just going to hand it off to you, Dick, expert.
Well, thank you. It's great to be here, and Yulene, it's great that you do these. The Medicaid budget this year was actually about as bad as any Medicaid budget I've seen, and I've chaired the health committee since 1987, so I've been through quite a few Medicaid budgets, through quite a few through 4 governors. The problem with Medicaid, it got sold to the public by the governor and largely bought up by the press that Medicaid was somehow overspending. And this conjures up images of, waste and abuse and, money going down the drain. None of that was involved. The so-called overspending is because in 2011, when Governor Cuomo first came in, he got the legislature, over my better judgment, to enact a cap on Medicaid spending, a completely artificial number, while it had an adjustment for a certain level of inflation. That was, a fixed formula that was not adjusted because of actual increases in inflation, and also had no provision in it for adjustments for increased enrollment or the needs of Medicaid enrollees. And as with every other aspect of society, we have been seeing more and more New Yorkers living longer, which is a good thing. But it also means their healthcare expenses going up, particularly for home care and nursing home care. And the governor's Medicaid cap makes no adjustment for that, just as it makes no adjustment for the fact that with the COVID-19 situation, we're going to see a dramatic reduction in income levels for millions of New Yorkers, which means more and more New Yorkers are going to be eligible for Medicaid, which will jack up the spending. Going into the budget, the governor said that projected Medicaid spending would be $2.5 billion just of the state share of Medicaid. We also get federal matching money. And if you cut Medicaid by $2.5 billion of the state share, that's about a 10%, 5 or 10% cut in the program, which is pretty hefty. We ended up, because of the governor's power in budget negotiations, we ended up accepting about a $2 billion cut in the Medicaid program. Now that cut is by and large not kicking in right away because, not because of any generosity on the state's part, but because with the COVID-19 legislation from Washington, we are getting about a $6 billion increase in federal money for Medicaid, but it comes with a condition, and that is that it says we have to have basically a maintenance of effort in Medicaid. So for as long as the federal increased funding continues, which will be presumably for several months, the various cuts in Medicaid that the governor imposed on us cannot take effect until after we stop getting the federal money. And so the budget legislation for most of the Medicaid cuts says that they don't take effect until October 1. So they didn't kick in April 1, they will so far kick in October 1, which is good because the longer we can avoid those cuts, the better. One of the biggest areas of cuts is in home health care. There are a couple of major hits there. One is eligibility for home care. We have significantly raised the level of need that you have to meet in order to qualify for home care. And you have to need assistance in 3 or more activities of daily living, like cooking, toileting, dressing, etc. Or if you are a patient with dementia, you have to also have 2 or more activities of daily living that you need help with. And there are going to be a fair number of people who would have gotten home care and need it, but will not be eligible because of this higher standard. And on top of that, previously it was your physician and the home care agency that you would use, and there were some other players that would determine what your need was, how many hours a day of home care you need, for example. We are now going to be farming that out to a corporation, presumably a huge corporation called Maximus, which already does a lot of the administering of our Medicaid program. And they will be choosing a panel of doctors who will determine how much home care you are able to get. One of the few good things we did in the budget in the health area was in the area of what is called indigent care funding for hospitals. It's something New York has done for decades. As of a few years ago, a large share of that money went to the major academic medical centers, like, not to pick anyone out, but Mount Sinai and New York Presbyterian and other big hospitals, Lenox Hill, and they got a disproportionate share of that indigent care funding, largely because of their political clout. A few years ago, we passed legislation redistribute that money so that more of it would go to real community-based safety net hospitals that deliver the bulk of indigent care to people on Medicaid, people who are uninsured, et cetera. We were phasing in that shift as of several years ago, but again, largely because of pressure from governors and the hospital industry, that phase in of the fairer distribution system was pretty much frozen. One of the good things we did in this year's budget was we implemented the full shift in the money to the new formula that drives more of the money to the hospitals that really take care of indigent patients, particularly for the New York City public hospitals and public hospitals around the state. So that was one of the good things we did. The last thing I want to mention, because I try to mention this every time I talk about the budget, New York State and this country as a whole does not devote enough of our wealth to the public sector, whether you're talking healthcare or education or mass transit or a host of other things. Every other industrial democracy spends a lot more of their national wealth on healthcare and human services and education. The way to fix that and the way to have avoided some of the cuts we did in this year's budget is with that word that politicians don't like to say, taxes. And, you know, I doubt anybody watching this town hall feels they are undertaxed, nor are they undertaxed, because average New Yorkers are overtaxed. The reason we're overtaxed is because we do not impose enough of a share of our tax burden on high wealth. And so people in the middle and the bottom pay more in taxes than they ought to and get less in services than we ought to. And unfortunately, in this year's budget fight, there was virtually no advocacy, certainly at the top level of the legislative and executive branches, on the tax question. And every organization that cares about anything in the budget, I believe, has got to join the effort to speak out. It's too late for this year, but we need to be working for next year's budget for a dramatic increase in taxes on big wealth. And, you know, some people say, oh, COVID-19, we're in a recession. How can you talk about that? Well, the people I'm talking about taxing, they're not losing their jobs. The people on Wall Street, what used to be called the captains of industry, they're not losing their jobs. And if the stock market was down for a while, it's bouncing back, and they have the good sense not to sell their stock when the market is down. They buy when the market is down. That's how they got to be rich. And so we really need to act. There's a variety of proposals for raising taxes on big wealth, and we really need to pay attention to that.
Thank you, Dick. And we also have, right after this panel, a panel on economic justice. So hopefully you can stay for that and talk about it as well. So one of the things that, you know, we've been getting a lot of, you know, thoughts on is obviously healthcare for our community health centers. So wanted to bring on Ding to talk about that a little bit. And Ding, introduce yourself with Apichak, and also help us to get us a little resource and knowledge about what's going on with our community health centers. You're on.
Okay. Thank you. Thank you, Assemblymember Niou, and of course, Dick Gartfried for this opportunity to be here and for organizing this. It's an important kind of conversation that must take place in our community. I'm the Chief Development Officer of Apichak Community Health Center. And as you know, while we serve the broader New York City communities, we do, as a federally qualified health center, we do have Lower East Side and the Chinatown area as one of our components of our service area as a federally qualified health center. So, being a federally qualified health center, we have to remain open to provide services, during this crisis. We are in the kind of in a background because our main purpose of being is to be able to make sure that we can help prevent people from going to the emergency room. We wanted to make sure that we have continuity of care even in this crisis. So another point of that is also because we are a community health center, our services are available to the community regardless of their ability to pay. Now, having said that, during when the crisis came about, Apichak, I'm part of a team of emergency 2019 COVID response within the organization. One of the things, of course, we wanted to make sure that the safety of our staff and our patients are taken care of. And then we also had to take on, so what is it, how can we provide the services under this condition? So we decided to implement telehealth. That's fortunately, prior to the crisis, we have already been investigating what telehealth in conjunction with our behavioral health services, so that when it was time to actually transform it, we were able to set ourselves up, the remote visits in a couple of weeks. So pretty much now, our patients are being seen either telephonically or through virtual medicine. And some, of course, there's still a few who need to come for various reasons that they require to, but we do have a skeleton force in the premises, and when a lot of our people are doing this online. Okay. You have asked about what kind of legislation can we possibly have under this condition? Am I jumping this? So the one thing that is really, I appreciate that, of course, the subways are getting clean. That's very important. We also learned that now the personal protective equipment, it's already being talked about as need, that we have to make sure that we have abundant supply, because that was one of the most disastrous episodes in this response to the crisis. So we do have to make sure that this what they call PPEs are available to our frontline workers who are interacting with the patients, and they are available immediately. Then, of course, we need to reflect on what it really means when our own health workers get sick. They do get charged with all the cost of hospitalization. Somehow we need to think about how they're going to be helped along those lines, because it's very expensive especially when you end up in an ICU. So then, of course, when we think about healthcare in this, the way we were beginning to shift care. It's not just our medical providers, but you are also talking about your care managers, and other support services, the behavioral health services, people who are part of that team that takes care of our patients. So, we are happy to report that, we did track our data so far. And during the first three, we went on telehealth on May 23 and tracked our data on that period. We were able to triage around 260 people who were reporting symptoms of COVID, and we were able to also continue providing services to our HIV patients, to people who needing PrEP visits, and also to the other patients who were just needing ongoing primary care.
Thank you, Jane. So I'm going to now call up Pauline, our DOH-MH representative. Okay. I'm unmuting you now.
Hi, good afternoon, everyone. Thank you, AssemblyMember Niou, for having me. So I will just go over the state budget for the health department. So obviously, because of COVID-19, the projected fiscal year 2021 state budget has been very scaled back. However, there are two bright spots for the health department. So one, it extends the authority for pharmacists to provide certain immunizations until 2022. And the list of what is currently allowed includes influenza, pneumococcal and meningococcal, shingles, and Tdap vaccinations. So we're hoping the list of allowable immunizations will expand beyond the 5, but we are glad that this authorization will not sunset this year. And there were also a number of important tobacco policies that passed as well. And in particular, the budget outlawed the sale of flavored vaping products in New York, and retailers who violate the ban would face a civil penalty of up to $100 per item. And other notable policies included the prohibition of sales of tobacco products, including vaping products, herbal products in pharmacies. So restriction on the delivery of vape products, and ending any online vaping sales. So these two things actually are very important and tie into COVID-19. Obviously, vaccinations are extremely important, and your general overall health prior to some pandemic is absolutely important. And we can talk a little bit more about the disparities that we're seeing in our neighborhoods a little bit later in case anyone has any questions about that. I'm happy to answer questions. And then again, vaping and tobacco and smoking, we all know that impacts your lungs. And in this particular pandemic, we do know that the impact of COVID-19 was in the lungs and the respiratory system. So I think overall, for the general health of New Yorkers, these two priorities are really important, and I'm glad that they are continued to be funded. So I can stop talking about this right now and then answer any questions people may have about COVID-19 specific questions.
Amazing. Thank you, Pauline. I'm going to keep you on the phone, so it makes it a little bit easier for us. Unless folks are answering questions, so then and background noise. We have a couple of constituent questions that are a little bit more specific, and then we also have a couple of constituent questions that are a little bit more general. And so I'm going to ask two of the general questions, and then I'm going to get to the more specific ones. So the general one is, how will the state ensure that New York's healthcare system fully recovers from COVID-19 itself? I'm going to give this to Dick and Pauline.
Well, of course, you're assuming that New York State will make sure that our healthcare system recovers.
This is my
and unfortunately, that that's always an open question. I think a couple of things. One, we need to have a very professional and independent team of people looking at that question, not only specifically how we recover from COVID-19 and what that may mean, but also we need to learn the lessons about our healthcare system that the COVID-19 epidemic is teaching us, about the weaknesses in the system, the problems that come from so many New Yorkers not being able to pay for their healthcare. And by the way, I'm not only talking about the thankfully fairly small percentage of New Yorkers who don't have health coverage, but millions of New Yorkers who have health coverage still can't afford their care because of deductibles and copays and restricted provider networks and the like. And of course, the way to deal with that, in my view, is to pass the New York Health Act, my bill that would create a single payer health plan. And I think people all across the country are, as a result of COVID-19, becoming more aware of how the way we currently finance healthcare has been making it difficult for people to get care, and how that has made people much more vulnerable to more severe symptoms and death. So we're going to have to take a very careful look at supporting our hospitals and home care agencies and community health centers and nursing homes. You know, there's been all this discussion about the horrendous situations in our nursing homes. We should also add adult homes and home care. And all of those sectors have for decades been severely understaffed. There's no news in that. And when you add on the care burdens that come with COVID-19 and the absentee rates among care workers, that makes the staffing shortages all the worse, but they've always been a serious problem. We're going to need to deal with that. And we're going to need to deal with the fact that, you know, people are shocked to find that there are problems in nursing homes and the health department wasn't on the case. Well, that's also nothing new. You know, our inspection and enforcement personnel in the health department have for years and years been seriously understaffed and pretty gentle, to say the least, in how they enforce the rules. You know, every year various national organizations put out rankings of nursing homes and the quality of care they give, the number of patients that have serious problems, et cetera. And while New Yorkers like to think that we must be best in everything, after all, we're New York, the truth is when those national rankings come out on nursing home care, we are consistently near the bottom. We're now seeing that very vividly with COVID-19. But we're going to not only need to recover from COVID-19, but to recover from the deficiencies that have been in our system all along. And you know, that understaffing and underfunding is with long-term care, it's with our hospitals, community health centers. We're going to need to address those problems or we're going to pay the price.
Amazing. Thank you. Pauline, did you want to add to that?
I don't believe I have anything additional to add to that.
I know, Dick is very, very thorough.
Yes, very thorough.
So here's another one. It has been said that the only way we will beat this virus is when a vaccine is available. Is that true? And how will we ensure that the vaccine actually works, and will everyone be able to receive it? Also, what about anti-vaxxers?
Well,
so vaccine, oh, go ahead.
No, Pauline, go ahead.
Sure. So I was just going to touch briefly about vaccines aren't the end all be all. There are different ways in which we could reach the other side. We're seeing that right now with the flattening of the curve, but we can't have people go out and not socially distance themselves too early because we don't want to see a second wave. Vaccines are incredibly important, as we know. Diseases have been eradicated, and we have been seeing some diseases come back in the recent years because people have decided not to vaccinate their children. And so from a public health perspective, we encourage everyone to continue vaccinating themselves and their children. And again, it's extremely important just to prevent diseases and to maintain an overall healthy body, so that when there is a pandemic like this, you have a better chance of being able to, recover or avoid it altogether.
The other big source of hope is medication, is drugs that will cure cases either fully or greatly reduce their symptoms. What is it? Remdesivir is showing apparently some promise. Other drugs are being developed and tested. So even if we can't stop people from getting the vaccine, if we can cure the disease, that's certainly second best, and may well become available long before a vaccine is developed and tested. A lot of people have asked, are the people who are opposed to vaccinations, how are they going to respond to a COVID vaccine? Well, who knows? It may well be that a lot of people will suddenly discover that vaccines are not the invention of the devil, but can in fact be life-saving.
So there was a couple of district folks who asked a couple of questions. One person was specifically very concerned about folks with developmental disabilities, intellectual disabilities, because she said that a lot of them have already ended up in emergency rooms due to COVID. So I don't know if you guys wanted to speak on that at all.
I guess it's a little outside my usual substantive turf, but I would say people with developmental disabilities, people with mental health issues, like people with physical disabilities or general infirmities of age, their problems are certainly highlighted and made worse by the epidemic, and all the things that we know can be helpful to those people, we need to be paying more attention to, as we should have been paying more attention to them for years.
Yeah, I think that disparities have really been highlighted across the board when it comes to healthcare, education, et cetera, et cetera, et cetera. The next question, and this one's from one of my very good friends, Melissa. I have a lot of concerns about the budget shortfall in relation to healthcare and how it relates to Medicaid and other patient assistance programs. I've talked to you, Lean, about the Adult Cystic Fibrosis Assistance Program that has been cut, which assists financially with for people with CF that I would love to see restored. Budget. It was $800,000. This is for Medicaid, but can't afford vital costly treatments. Also, there are 33% of adults and 50% of kids with CF who rely on Medicaid coverage, as well as many other populations. What can officials do to protect access for coverage for people with cystic fibrosis, as well as the many people who rely on Medicaid? So I think they're asking in terms of the cuts right now. And I mean, everybody can answer that one. I know that a lot of our community health centers and our, and of course our city government and our state government have certain things that they're feeling in regards to what's going on, but also, with the services that they're providing, et cetera.
Yeah, I want to, can you, am I, okay. Yeah, you can hear me. Okay. Yeah, just going back to what I said earlier, we are not existing, community health centers not existing in a vacuum. We're all affected by what's happening. So what's cut in one side somehow also affects us in various ways. That goes back to this whole notion of, ongoing primary care, whether you are a person with disability or not, we still would promote the importance of ongoing primary care. And there are people who recovered from COVID. Many of them may not have primary care providers, and that's how they ended up in the hospitals. But so in this coming period, if we were to recover from this, it's important that we do everything we can to reach out to the communities that we serve, so that they can then access our services. The problem, though, is that in the course of this budget cuts and things like that, a lot of these services that are related to outreach to these communities are going to be the ones that are going to be on the chopping block. Now, so, even before that, we already looked at how important it was to have this aggregated data. Up to now, we still don't have this aggregated data on Asians and Pacific Islanders. And we hear a lot of complaints from when the crisis in Elmhurst happened. A lot of these folks are from these communities that have a lot of cultural and linguistic, distinct needs that could have been addressed had we had the data, so we would have known how to do our customized outreach to these populations.
Thank you, Ding. Did you want to add anything, Pauline?
No.
Okay. I just wanted to follow up with Deborah's comment to Assemblymember Gottfried. Dick, so she just said, Assemblymember Niou knows of these concerns, but one of the issues that is contributing to the concerns with persons with IDD is the lack of availability of behavior analysts beyond individuals with autism. It is not equitable that you can only get the services if you have autism. Unfortunately, if we don't fix this, the numbers will continue to increase. Behavior analysts are needed for simple things like helping families and group home staff to teach how to wear masks, all the way to helping with severe challenging behavior. We are so hoping that Bill 6389A in the Assembly and Senate Bill 4967A can pass this session so that individuals and families can get the help they need, and to help keep individuals out of the hospital to every degree possible. So I mean, there's more of a statement, but I know that you have probably some.
Yeah. Well, as our questioner probably knows, it took a lot of effort over a period of years to get ABB services accepted in New York for coverage for people with autism. I think it's going to take a major effort, hopefully fewer years to do it. It'll take a major effort to get that done, I expect, to get it done for people with other conditions besides autism. It's something that I would guess most legislators are at this point not really familiar with the use of ABB outside of the autism population. So there's an advocacy effort that's going to have to go on there.
Amazing, thank you. And Deb has been advocating hardcore, so we want to say thank you for that, because without your voice, we wouldn't be able to have that perspective. We have one more question on the healthcare side. That is with a, Given the current health crisis, how can we ensure that every patient that needs care will receive care?
Well, you know, my answer to that question is the same as my answer to a lot of questions, which is we need a universal single-payer health care system so that we can get rid of the financial obstacles to getting care. That's important to individuals being able to get the care they need. It's important for hospitals and home care agencies and community health centers and others having the funding that they need to be providing that care. I think organizations that have not gotten on board with fighting for that issue really need to. There are, I would suggest, two places that people can contact. One is if you Google an organization called the Campaign for New York Health. That's the main organization campaigning for the New York Health Act. People can also contact my office or State Senator Gustavo Rivera's office. He's the Senate sponsor of the bill, and we can send people more information about it and help get you connected to the campaign for it.
Pauline, did you have anything else on that question?
Yeah, I think, you know, having people and New York City residents as a whole in general having better health from the beginning of life is also very important, because obviously we know hospital beds are finite, right? There's a certain number of hospital beds available to people. And so if we can get our populations to be as healthy as possible, closing those disparities, closing the gaps, and having people be able to have access to those fresh fruits and vegetables, and having people and communities be much healthier from the beginning of life, then, you know, when there's a pandemic like this, there will be a general healthier, more robust population that will not be as likely to be dependent on the healthcare system. So I think the goal of the health department, of course, is to be able to work in those communities most hardest hit now, but even prior to this, you know, closing the gap, having our health equity teams be in those communities and to work on priorities in making sure our neighborhoods and our residents are as healthy as possible.
And Ding?
Yeah, I do have something to add. Assemblymember Godfrey, you mentioned about, you know, the need to actually sustain the health centers and our medical healthcare system. There is one strategic issue that's actually concerning with respect to the current language in the budget, and that has to do with the pharmacy carve out, you know, which we believe will impact the health centers and other hospitals that may be using the money that is saved from 340B program. So that is something that, you know, is beginning to emerge, because there are many of us in the state of New York that's been providing services to our HIV folks, as well as for other, you know, reproductive health issues and LGBT issues that are using savings from the 340B program. Now, with the language that's in existence now, it looks like we will not be able to anymore, you know, with the transfer to the FFS. My understanding is that, you know, we will no longer be able to avail of that savings if that were to go through in 2023.
Right. So we're well aware of that issue. The language that got enacted in the budget was pretty much dumped on us by the governor. We didn't really have an opportunity to, I mean, we offered alternative language, but they didn't accept it. I've been working with on new language to remedy the 340B problem. And for the people listening in, I think either of us could try to explain it, but we probably need another half an hour. But
We don't have that, sorry.
right, we are working with Chicanis, the organization of the community health centers, and with some of the Medicaid managed care programs that focus on people with HIV to develop language, which I'm quite certain we can do, that will resolve the 340B issue there and get things back on track. Getting the governor to accept it will be the next step.
And so one last statement from Rocky Chin, one of our former panelists and current panelist, I guess. AARP welcomes support from Assemblymember Gottfried and colleagues from the Assembly regarding long-term care task force. We need the Assembly and the Senate to advocate to Governor Cuomo to create it ASAP. Thank you, Rocky Chin and the AARP. So I agree, Rocky, you got my support, and I'm sure that you've got everybody else here's support. So.
Yeah.
I just wanted to say thank you to everyone for all of your advocacy and all of your work. You know, our district, actually, we had a long-term care facility that we lost, and it was very, very hard for us. You know, people know it as Rivington House, and you know, we need our long-term care facilities. We need our healthcare, you know, safety net to be working. And there was somebody else who had said something about Medicare for all day, and I think that we have to make sure that we advocate for Medicare for all. Thank you so much for all of your support, Dick, and Ding and Pauline for being here and helping us to get through our budget today on healthcare. So again, just wanted to say that without all of the advocates and without all of the advocacy work that we're doing around healthcare, we won't see the kind of recovery that we want to see. And you know, COVID has really shined a spotlight on all of the things that are missing from our government system of healthcare, and from a lot of our social services, and from a lot of the things that we need to be a robust and have a robust public healthcare system. And you know, this isn't a system that is broken. I like to say that a lot, but it is a system that is designed to hurt particular communities. And I think that it has done its job. And we need to make sure that we are dismantling the system and changing things in a very real way to make sure that we have the change that we want to see in our healthcare system, and in a system of government that will make it so that we value people over profits, and people over money, and people over even our own budget needs in our state level. So thank you so much to all of you, and thank you so much to our amazing chair for providing all of this information.
My pleasure.
Yes, you're the guy with the facts and stats, man.